Welcome, everyone, to this week's special Grand Rounds, and that this is actually the annual Fialkow Scholar Award presentation. And the Fialkow Scholar Award was established in memory of Philip and Helen Fialkow by the Department of Medicine. And Dr. Fialkow, Dr. Phil Fialkow, was the former chair of the Department of Medicine and also the former dean of the School of Medicine. And this award was established in recognition and support of a junior faculty member who shows outstanding promise as a scholar. Both Helen and Phil Fialkow always had a keen interest in the progress of junior faculty and sought to promote their careers and they had the strong interest in faculty development and in scholarship. But here's a list of the past recipients of the Fialkow Scholar Award. You can look at the list there. There are a few individuals that you may recognize on there. And I am pleased to announce that the recipient of this year's Fialkow Scholar Award will be Dr. Josh Hill. And Dr. Josh Hill is in the Division of Allergy and Infectious Diseases. And Dr. Hill will have his name emblazoned on a plaque upstairs here at the Department of Medicine, but he also receives $10,000 to support his academic program as a recipient of this Fialkow Scholar Award. And to introduce Dr. Hill, I'll turn it over to Dr. Anna Wald, the division head of the Division of Allergy and Infectious Diseases.
Thank you, Conrad. It gives me great pleasure to introduce Dr. Josh Hill, who's assistant professor, both at the University of Washington and also at Fred Hutchinson Cancer Research Center. Josh came to Seattle originally from South Africa and then Texas. He did his undergraduate degree at the University of Texas in Austin and then medicine at Texas Southwestern in Dallas. He then went to become a resident at Brigham and Women's Hospital in Massachusetts, and we were lucky enough to get him to come here for his fellowship. Josh's work has focused initially on HHV6 infections and other viral infections as well, but then really focused on infectious complications after CAR T-cell therapy for malignancy. And he currently has a U01 to study humoral immunity after CAR T-cells, and is also very well funded with many other ongoing projects. And I should also add that he has now more than 60 peer-reviewed publications. We're looking forward to your talk, Josh. Welcome.
And before Josh begins, I want to remind the audience that if you have questions, please post them in the chat or type them into the chat. And then those questions will be posed to Josh at the end of his talk. Thanks.
Great. Okay, well, thanks so much both to Conrad and to Anna for that introduction. Let me get a pointer going here. Perfect. And thanks to everyone for your interest and attention today, for those of you who are joining. Certainly was hoping that we'd be able to do this in person, but that was not to be, unfortunately, but I'm happy to be here with you all virtually nonetheless. So as Anna mentioned, I'd like to spend some time with you today talking about some of the work that I and others have been doing, looking into infections in patients who are receiving these novel CAR T-cell therapies. And I'll talk with you more about what exactly those are in the course of this discussion. And I've entitled this talk as a paradigm on the move, mainly because this is a relatively new field and there's still lots to learn and lots of things are changing rapidly. These are my disclosures here, none of which are related directly to the work that I'll be discussing today. So I just wanted to start off with a round of acknowledgements, first and foremost to Dr. Philip Fialkow and his wife, Helen Fialkow, who this award is in honor of, and to their son, Dr. Michael Fialkow, who I think is able to join us today and is a faculty member at the University of Washington. I'm very honored to have been selected for this award. Next, I wanted to acknowledge and thank other mentors who have really helped me navigate the field of academic medicine and academia over the past, I guess, 8 years or so now. And it's oftentimes a very winding course and challenging to navigate. Michael Book has been with me from the start when I came here, along with Dr. Danielle Zaire. And I connected with Dr. Cam Turtle probably 3 or 4 years ago as I became interested in CAR T-cell therapy. He was a prior recipient of the Fialkow Award actually a few years ago and has really been a pioneer in this space of CAR T-cell therapy at our institution. Steve Pergam has just been a guiding light throughout for all things work and life related. And then, of course, my wife, Dr. Desai at Seattle Children's Hospital, who's been navigating this whole process of academic medicine alongside with me. Next, I'd like to recognize and dedicate this talk to Dr. Francisco Marti. Dr. Marti was my first mentor, I would say, when I started residency in Boston. And he really got me started on the path of transplant infectious diseases or infections in immunocompromised hosts. So I think I really owe my start to him. We tragically lost him this year in an accident. And I was allowed to participate in a memorial that we wrote for Francisco in the journal that he was a chief editor for, Transplant Infectious Diseases. And in that process, we were able to reflect on what Francisco would do and what he would want us to do. And he really, I think, embodied the qualities of what the Fialkow Award is really striving to support. So Francisco would want us to be generous and thoughtful mentors and teachers. He would have wanted us to believe in people's potential and to be forgiving, to practice the art of medicine joyfully, and to never lose sight of the privilege of taking care of people, to be eternal students, relishing the fascinating aspects of medicine, retaining humility, and always going the extra mile for our patients. And for those of you who are lucky enough to know Francisco, he always was one to push the boundaries of the field and to challenge the status quo. And he didn't back away from that when he thought it was important. And finally, to keep each research question firmly rooted in how it might improve the care of our patients. So these are certainly ideals that I will continue to strive for and hope others do as well. Okay, let's jump into the talk here. So broadly speaking, as you've already heard, my interest has really been focused in infections in immune-compromised hosts. And initially that was really focused in bone marrow transplant recipients who developed viral infections and other types of infections. But as Anna mentioned, over the past few years, I've really become interested in chimeric antigen receptor T-cell therapy. This is a novel type of immunotherapy to treat patients with refractory malignancies, mainly hematologic malignancies right now. And this really was a brand new approach to treatment in our patients and has had a number of commercial approvals, which has opened up a lot of opportunities to both understand how to provide appropriate supportive care for our patients, as these individuals have a variety of kind of novel risk factors for infection. And that's really where most of my work has been lately and where I'd like to focus today. So this is a presentation of what I will be walking through with you today. Initially some background, and then thinking a bit about both the acute and then some of the long-term infection risk factors and complications in this patient population. And then thinking a little bit about additional supportive care strategies such as vaccination and other future directions. So to give a little background to people that may not be familiar with what CAR T-cell therapy is exactly. So CAR stands for chimeric antigen receptor. And this is probably a new concept for people that haven't otherwise been interested or following this space. So it's a really fascinating concept. So this schematic tries to break it down a bit. And what the CAR consists of is this part of the schematic here in yellow and green. And it consists of a single chain variable fragment, which is derived from a monoclonal antibody specific to a tumor antigen. So in green here, this is basically an antibody that recognizes whatever target you want it to recognize. So this is the engineered piece. And that is linked to an intracellular T-cell signaling sequence. So it's a chimera of an antibody and a T-cell receptor signaling sequence that's expressed by a patient's autologous T-cell. So this is an engineered T-cell from a patient that's designed to express this CAR, and you can make it target whatever you want it to target. And for the most part, in this talk, I'll be talking about CD19 targeted CAR T-cells, which specifically were developed to target a range of B-cell hematologic malignancies. So that's the basic concept. This schematic depicts from a high level how these T cells are generated and administered. So if you have an individual with a hematologic malignancy due to B cells, you do leukapheresis to extract their T cells, and then you engineer these to express the CAR on their surface. You basically introduce the genetic code, and then they will express that protein on their surface. You expand these in vitro, and then you reinfuse them into the patient. And this is being done primarily for lymphomas and acute lymphoblastic leukemia, now most recently for multiple myeloma, and has been studied for CLL as well. And has had really, striking success rates, the response rates up to 70 to 90% in people who had otherwise gone through, all their other options at that point and would otherwise potentially move on to hospice or some other salvage regimen. So really an exciting milestone in the treatment of cancers. This is a bit of a busy slide. This was adapted from a slide that that was kindly given to me by Dr. Jordan Gauthier here at the Fred Hutchin UW. And this is looking at the timeline of FDA approvals for CAR T-cell products, just to give you a sense of the pace of this. So the first approval was in August of 2017. The names are really wild here, and they're indicated here at the bottom. This was for pediatric and young adult patients with refractory or relapsed ALL. Since that time, we've got about 5 products that have been approved for either new products for new indications or existing products for additional indications. All of these so far have been for lymphomas and leukemias, and all of them have targeted CD19, except for this one, which is kind of the first in class in March, early this year, was approved for multiple myeloma. And this one's unique because it targets a different surface antigen, BCMA. So the rest of these are CD19 targeted CARs. This one is a BCMA targeted CAR, and we'll talk a little bit more about why that's relevant and interesting. So a very quickly moving space, lots of excitement here in this area. I believe when the first product was approved, this was the first engineered T-cell product that had ever been approved by the FDA in the US. So what are the side effects of CAR T-cell therapy for hematologic malignancies? I think that's kind of, from my perspective as an infectious disease physician and researcher, the interesting question here, and why is that relevant in these patients? And I think of these individuals as having a high net state of immunosuppression. These are highly immunosuppressed patients. As I mentioned, that most of them have received extensive past therapies. The majority of these patients have often had a prior allogeneic or autologous bone marrow transplant, so very immunosuppressed individuals. We may see approvals in the future to use these therapies more upfront, but right now they're for patients with refractory disease. In addition, these patients get additional lymphodepleting chemotherapy before their CAR T cells get infused. This is sort of like a conditioning chemotherapy that really optimizes how well the CAR T cells expand and function. And immediately after infusing CAR T cells, patients are at risk for cytokine release syndrome and neurotoxicity. We've, of course, heard a lot about CRS in the context of COVID-19 and the overlap where you see that with CAR T-cell therapy. And a lot of the CRS understanding comes from CAR T-cell and bone marrow transplant patients as well. And then perhaps what's most interesting is that even though these CAR T-cells are quite precise, and I think you could say they're precision medicine, they're not perfectly precise. And so you do have collateral damage as you deplete the malignant CD19 or BCMA expressing B cells. You also kill off all of the normal and other healthy B cells that also express those surface antigens. And so I think that has a lot of relevance to what we're talking about today. So in the schematic, what I'm showing you here is a T cell from a patient that has this CAR on its surface that recognizes CD19. And when it binds CD19 on a malignant cell, we call that on target, on tumor effect. If it binds CD19 on a naive or memory B cell, that's a healthy cell that's not malignant, that's on target, it's binding CD19, but it's off tumor. So this is kind of the collateral damage or a side effect, and you can deplete all of these healthy normal B cells. What's also interesting to think about is which cells are affected. So for CD19, this is pretty universally expressed on pre-B cells, naive B cells, and memory B cells. So all of these are anticipated to be depleted. However, plasma cells, which are really the kind of the final maturation phase of B cells, tend not to express CD19 or downregulate this. These plasma cells are typically what's responsible for producing most of your long-lived antibody responses to prior vaccinations or previously encountered pathogens. So these plasma cells may actually persist despite this therapy. If you get BCMA targeted CAR T cells, it's actually the flip, and we'll talk about that in a minute. So in addition to all of the kind of prior chemotherapy that these patients have gotten, they can get additional cytopenias after CAR T cell therapy. So these schematics are showing, for instance, CD4 counts. They get chemotherapy before the CAR T cells are infused. So you see CD4 counts go down, and then they start to recover. For CD19 expressing B cells, as you'd expect, by day 30 after getting this treatment, all of your healthy and hopefully malignant cells are killed, and that's indicated in this figure from a study. And then you start to get some recovery of that about 6 months later, and that continues a little bit throughout a year. But CAR T cells are actually a living drug, so they can continue to replicate and persist in individuals who are treated for up to years in some instances. So you can get really prolonged cytopenias, and up to 10% or more of patients by a year out still have some component of immune deficit from these therapies. So next up, we can move into thinking a little bit about what types of infections are we seeing in these patients. And this was really an open book. Aside from some of the phase 2 and phase 3 clinical trials that were published that maybe had some vague mention of infections as an AE in a supplementary table, there were really no systematic studies looking at this. So this was an area that I was happy to dive into here, working with the immunotherapy program to try to understand just what is the epidemiology of infections in these individuals, what do they look like, how frequently are they occurring? So we retrospectively studied 133 adults who had been treated here as part of a phase 1, phase 2 trial with ALL, CLL, or lymphoma. This trial was run by Dr. Cameron Turtle, and Dr. David Maloney. And what we saw, we really focused on the first 28 days initially, and you can see about a quarter of individuals had any microbiologically documented infection. The majority of these were bacterial infections, and about 17%. Viral infections were common, but about half as common. And then we did see some invasive fungal infections. Some of these were mold infections as well. So those can be pretty devastating in this patient population. That was done with Dr. Turtle. Next up, we were interested in doing a similar study in pediatric and young adult patients. And so we partnered with some of our colleagues over at Seattle Children's Hospital and did a similar study in patients that received this product across the street. And what we saw was a cumulative incidence of about 40% of kids and young adults had infections. So that's quite a bit higher than what we saw in the adults. And here, this is pretty evenly split between bacterial and viral infections. And again, a small proportion of individuals are still affected by invasive fungal infections. And that work was done with Dr. Rebecca Gardner and Dr. Sarah Vora at Seattle Children's Hospital. So we subsequently also thought about what's the kind of longer term risk in this patient population. So now that patients are cured of their malignancy after the acute effects of chemotherapy have worn off and some of the side effects from cytokine release syndrome, what does it look like 6 months, 1 year out? So these are data from another institution, 85 patients treated with a product for lymphoma, and they really reflect the data that we generated as well. And what you can see here, this is an incidence rate of infections on the y-axis over time on the x-axis, is that the incidence rate really plummets after the first month. So most of the infections are in the early time period, and then they go down after that, as one might expect. Still not a whole lot of data in the long-term follow-up in these patients, but we're definitely learning more. In a study from our center, we looked at 1-year survivors and who were in remission and what types of infections did they get and how frequent was it. And on average, these individuals were getting about 2 infections a year. And these were really predominantly upper respiratory or lower respiratory tract infections, so sinopulmonary infections, which is something you might expect in someone with B-cell deficits with hypogammaglobulinemia. So that kind of fits. And then of those who did get admitted, mainly involving the upper and lower respiratory tract and predominantly viral infections that we're seeing, although some bacterial infections as well. So I had an opportunity to write an article for the How I Treat series, kind of an expert guideline for thinking about infections after CAR T-cell therapy. And we made this schematic to start thinking through this. And this was adapted from a figure that's used in bone marrow transplant as well. And kind of in this early phase of acute toxicities in the first month, cytokine release syndrome is one of the main risk factors, which I'll show you in a couple of slides from now. And mainly we're seeing bacteremias and bacterial infections, and then some of the other viral infections and some fungal infections over time. And then the schematic just kind of lays out what happens in the different phases as patients recover after this type of therapy, and is a little bit of a roadmap for thinking about how to manage our patients, how to prophylax, what to look for. So obviously we'd like to know what are the risk factors. Can we predict who is going to develop infection and when it's going to be more frequent? So each of these plots looks at a different risk factor. If you just focus on the solid lines, in this first plot, looking in the first month after CAR T-cell therapy, we looked at individuals in the blue line who had ALL, those who had CLL, and those who had non-Hodgkin's lymphoma. And we clearly saw that those with ALL appear to have a higher overall incidence of infections in that early time period. We also looked at the number of prior therapies as a stratification variable, and you can see those who had 4 or more prior lines of therapy had an increased risk for infection. We also looked at the CAR T cell dose level. This study was a dose finding study. You can see very clearly here that individuals who had the highest dose level 3, clearly had the highest rate of infections. And what we think that's due to is toxicity. So these patients also had the highest level of cytokine release syndrome, which appears to be the driving factor here. So these are data from Memorial Sloan Kettering, 53 adults with relapsed ALL. And what they did here is they looked at the cumulative incidence of infection stratified by the grade of cytokine release syndrome. And in those with grade 3 or higher, so more severe cytokine release syndrome, you can see these individuals clearly had a higher incidence of infection. And when looking at bacteremia specifically, almost all the events were in those individuals that had more severe cytokine release syndrome. And this is probably driven by the fact that those individuals are getting hospitalized, sometimes in the ICU, requiring steroids, and have all those other risk factors that come along with those sorts of interventions. So we and others put the data together in some models. And so these are data from our studies, from those at Sloan Kettering and from Seattle Children's Hospital. And really in our data set, when we looked in adjusted multivariable models, really CRS, cytokine release syndrome toxicity, was the main factor after adjusting for other factors that was associated with increased risk. So for every step up from no CRS to grades 1 to 3 to grades 4 to 5 in CRS toxicity, you get about a 3-fold increase in the risk for infection. There was a similar finding at Sloan Kettering, and in our pediatric cohort, we didn't see a strong effect due to CRS. There was less CRS in that group overall, and they were also more aggressive about preempting CRS. So perhaps that was successful here, seeing that there wasn't a strong association, but individuals with prior transplant and hypogammaglobulinemia at baseline appeared to have increased risk. So all of those data were from patients getting CD19 CAR T cell therapy. I mentioned at the beginning that the first product for BCMA targeted CAR T cell therapy was just approved. This is specifically for patients with multiple myeloma, which is a disease of plasma cells, which specifically express BCMA. So this is a new patient population that we're starting to study, as the first commercial approval just happened now in the past few months. We're just starting to see some data coming out. We've been looking at this here at our institution, and what we see is a relatively similar pattern, although some differences to CD19. I didn't show you the same type of plot for CD19. This is an incidence rate, the number of infections per 100 days at risk on the y-axis, and different time periods on the x-axis. In the CD19 group, the numbers are more like 1.5 here. So about half as many infections in general in the BCMA CAR T group. And it tends to be evenly split between viral and bacterial early, and then viral infections clearly predominate later on. But again, you see this pattern of reducing infections over time in this patient population. And this work is being led by Dr. Jostula, who's currently a chief resident over at Harborview, and in collaboration with Dr. Damian Green, who leads the myeloma program. So I think there's going to be some interesting findings, and I'm going to show you some more data in relevant sections from BCMA versus CD19 as we move through this talk. So long-term infection risk after CAR T cell therapy is something that I think is going to be clearly important as more and more individuals are getting treated and cured with these infections. And so, you know, that leaves us thinking, all right, are our patients in the clear now? Are they driving off into the sunset happily on their way and no other issues? Or are there some holes in the ship, and are there some other issues that we need to think about to keep our patients afloat? And although I do love sailing, I promise this isn't a selfie, although others may tell you otherwise. And this has kind of led me to think a lot about what sorts of risk factors do these patients have in long term, and how do we best support that? So bear with me as I walk you through a schematic that I made here to try to think through and hypothesize what we might see clinically based on the immunology that's happening here. And the key question, I think, is previously acquired humoral immunity preserved? And it looks like I skipped this slide. So I'll just quickly address this. And the question is really, how do we approach long-term infection prevention? And part of the reason why I'm interested in studying this is because many of our patients get put on monthly indefinite IVIG replacement, intravenous immunoglobulin, sometimes sub-Q immunoglobulin. So this picture here is Emily Whitehead. She was the first child, the first person, I think, to get CAR T-cell therapy as part of a clinical trial at CHOP, I think now 8 or 9 years ago. And she was actually cured, which was great. And she now has created a foundation and blogs about her experience and her condition. And she reports that she continues to get monthly IVIG. She's healthy, cured, back in school and back to life. And so IVIG is extremely expensive. It's up to $5,000 to $10,000 per infusion. It does have side effects. It's logistically challenging for lots of people. And there's national shortages. We definitely experienced that quite a bit over the past 2 years in the context of COVID and lack of blood donations. So this is a not always easy to access product. And there's lots of questions about whether we need to be doing this. And we really don't know. This is being done because most of these individuals have hypogammaglobulinemia, but what that means in this context is not entirely clear. So back to this figure here. So in this schematic, I'm showing you here an adult who's pre-CAR T-cell therapy, hasn't been treated yet, and I've simplified what their bone marrow might look like. So the purple cells here are plasma cells. These are your terminally differentiated B cells. The orange and the yellow are memory and naive B cells. And after CD19 CAR T-cell therapy, you'd expect the naive and memory B cells, which express CD19, to all be depleted, but these plasma cells, which don't express CD19, to persist. And since those produce your antibodies, if you're thinking about antibody titers pre-CAR, so if you have protective levels of antibodies to SARS-CoV-2, for instance, or measles, you'd expect that to be flat. You'd expect that to not change because of this therapy, because your plasma cells persist. Same for your diversity or your antibody repertoire. If this dashed line here is a normal repertoire, you'd expect some of these individuals to come in perhaps lower than that because of their prior treatments, but to be stable due to the preservation of long-lived plasma cells. In pediatric patients, you'd essentially have the exact same scenario, but perhaps they have fewer plasma cell clones in their bone marrow because they haven't had as many vaccines, they haven't had as many infections. So you'd expect their antibodies they start with to remain and be stable, but perhaps their diversity is at a lower set point. Now, the interesting case comes up when you're talking about BCMA CAR T-cell therapy in adults with multiple myeloma. In that instance, you're targeting BCMA expressing plasma cells. BCMA is not expressed on early and naive and memory B cells. So you have the complete flip here where your plasma cells are all depleted, but your other healthy early and memory B cells are preserved. And in that context, what you'd expect is to really have plummeting levels of pre-existing antibody titers for any given pathogen, as well as diversity. So that's the general framework that we were kind of thinking through and working off of here. So to start to answer some of these questions and explore these, we wanted to initially do a cross-sectional study of patients who've been treated with CD19 or BCMA CAR T cells at our institution over the past 6 to 7 years, who were at least 6 months out from their treatment, were in remission, hadn't received additional chemotherapy or required transplants or anything else, and were back out in the community. So in this group of patients that we approached, we collected blood at one time point per patient, and we tested this for antibodies to 12 vaccine-preventable infections indicated here. And this work was led by a visiting fellow from Switzerland, Dr. Walti, and others in my group here as well at Fred Hutch. So we were able to recruit 65 individuals, mainly those who got CD19 CAR T therapy, as well as some who got BCMA CAR T therapy. This was really a tour de force. After CAR T cell therapy, patients certainly come to our center from all over the world, all over the US, so they've all kind of gone back to their homes. So finding these patients, getting in touch with them and organizing this was really a logistical tour de force for our group. Most of these individuals were older, although there were some pediatric and young adults included as well. Patients were anywhere from 7 months to up to 5 years after CAR T cell therapy, with diagnoses that you'd expect in each of these categories. 44% of people in the CD19 group had had a prior transplant, and 73% in the myeloma category, the BCMA population, had a prior transplant. And most of these individuals were heavily treated, as we've discussed already. So I'll walk you through this figure here, which really shows some of the high-level data. And the takeaway was that our hypotheses really held here. We saw similar proportions of CAR T-cell therapy recipients had seroprotective antibody titers to vaccine-preventable infections when you compared it to surveys done in the US population. So the way that this figure is organized here, on the x-axis, you have the different vaccine-preventable infections we were interested in that we tested for. And on the y-axis, I'm showing the proportion of individuals that had a protective antibody titer to that pathogen. So for VZV in the dark blue group here, about 90% or so of individuals, 95%, had seroprotective antibody titers, despite being 6 months to longer out from CAR T-cell therapy. In the gray bars are the US reference. And so looking across this plot for basically every pathogen, you can see that the dark blue and the gray bars are pretty similar. There's some limitations in these comparisons, but overall it looks like our CAR T-cell recipients are similarly protected after CAR T-cell therapy for vaccine-preventable infections. In the light blue box in each of these are individuals who were getting IVIG, and you can see, as you'd expect, that does bump up the proportion of people that had seroprotective levels. They were getting supplemented. So you can see that here. And that's particularly relevant. You see it down here for hepatitis A, B, Haemophilus, Streptococcus pneumonia, and pertussis. And you can see for strep pneumo that actually nobody met criteria for seroprotective titers. So this is starting to help us think about how we formulate guidelines for who should get IVIG versus vaccination. But for the most part, you can see that it's not like these patients have no antibody titers. So the next question was, well, what about CD19 versus BCMA? And we were able to do that in this study. And our hypothesis was, of course, that antibodies would be pretty stable in CD19, but in our BCMA myeloma patients would have fewer antibodies. And that certainly did play out here. The numbers were relatively low, but the blue bars are now CD19 patients. The orange bars are people that were treated with BCMA. And for every pathogen, you can see here clearly that the BCMA CAR T recipients had a fewer proportion of individuals were protected for every pathogen. There was one individual in this cohort who actually had 0 seroprotective antibody titers for any of the vaccine-preventable infections. So really quite striking and consistent with what we hypothesized based on the biology of what was going on. When you put these data into a generalized estimating equation formula, when we did the stats on this, we were able to make some interesting observations. So first of all, we saw that on average, as I've already shown you in the figures, patients getting BCMA CAR T-cell therapy had on average fewer seroprotective antibody titers compared to CD19. But what was, I think, really telling was looking at total IgG and CD19 B cell counts that we tested at the same time point. And what you can see here is that based on patients' total levels of immunoglobulin G in their blood, there didn't appear to be a difference. So if you were severely hypogammaglobulinemic, less than 400 milligrams per deciliter in the blood, you were just as likely to have a seroprotective antibody titer as individuals who had normal or higher levels of total IgG. So, and having severe hypogammaglobulinemia in this population is the rationale for giving IVIG, but it certainly doesn't seem to hold. And what's known is that total IgG does not really appear to correlate very well with pathogen-specific IgG, and that's shown here in this study as well. So I think that's an important finding, as well as looking at absolute B cell count. So, a lot of the general thoughts in the field were that, all right, if you've got low or no B cells detected in your blood, certainly you're not going to have any antibodies detected. But I think that's the wrong way to think about it, because our plasma cells aren't captured in this metric, and those are what are responsible for making your antibodies. And sure enough, when you look in the model here, there was no difference in antibody titers that were protective when you looked at people that had very few B cells in their blood versus higher B cells in the blood. So this is all just going to show that these are probably not good metrics to guide our infection prevention strategies. So the main limitation of this study that I've just been talking about here is that this was cross-sectional. This was a single time point after CAR T-cell therapy. So obviously we'd like to know more of a longitudinal look. What do these patients start off at, and how does their CAR T-cell therapy affect that? So that's some work that we've started to dive into. Here are some data from that. So in blue here are individuals who got CD19. In red are individuals who are treated with BCMA. And on the x-axis, I'm showing you a sample that was tested pre-CAR, and then looking over time, the number of days after CAR T cell. On the y-axis, I'm showing you a measles antibody quantitative level. The reason we chose measles antibody was because this is something that basically everyone has been vaccinated for or was previously infected with, and there are extremely stable half-life for measles antibody levels in the blood. So you'd expect a very stable antibody titer over time in individuals, and you'd expect everyone to be seropositive, seroprotected prior to getting their CAR T cells. You can immediately start to see some interesting differences. So in the CD19 treated patients, you can see the majority of them, anyone above this dashed line, is positive. So the majority of them are seroprotected pre-CAR, and for the most part, they stay quite flat over time. There is this one individual who dropped, and this patient had a prior transplant, and that's a known phenomenon. But for the most part, 75 to 80% were seroprotected, and they stayed flat. So clearly there are some people that start off seronegative, and there's some gaps here that's concerning in the context of a resurgence in measles. When you look at the BCMA population in red, you can see the flip, actually. The majority of individuals are seronegative, and this was quite striking. I think about 80% of individuals in our data set here are seronegative even before they get their CAR T cell therapy. And in the few that are seroprotected, you can see this really dramatic drop in their antibody titers, as you'd expect with the BCMA treatment. And at the end of BCMA CAR T cell therapy, when patients are 6 months out, almost nobody, I think there was one individual who was still seroprotected. So this is an extremely high-risk patient population, I would say, based on these data and what we know about the biology. And if you had to steward IVIG to a specific patient population, I think you could make the argument that these are individuals that would be more likely to benefit from it. We're expanding this work as part of the U01 grant from the NIH that Anna mentioned, in which we're doing a prospective longitudinal study to really capture blood and samples over time to do a broader look at these sorts of questions. So in summary, what I've shown you here is that seroprotection for vaccine preventable infections in adult CD19 CAR T cell recipients was comparable to the general population. We didn't have enough kids involved to really make a comment there. The BCMA CAR T cell recipients had fewer pathogen-specific antibodies, but clearly there are some deficits in both groups that support the need for both randomized trials of immunoglobulin replacement therapy to see whether or not it's beneficial or not, and thinking about vaccines in these patients to try to supplement them when needed. Okay, I think we've got some time to talk about some vaccination strategies and future directions, which I'd like to talk about next. So this was a question that I thought was really relevant, even prior to COVID-19, certainly. And this study started before that. And we wanted to perform a prospective observational study of influenza vaccination. We started this in the 2019 to 2020 influenza season. And the reason we wanted to study this question was, first of all, because there was no data at all published at the time. Of course, since SARS-CoV-2 since the pandemic started, lots of interest was generated in this space. And there's a few studies that are out now with SARS-CoV-2 vaccines. But at the time, nothing was known. And for the most part, people were biased to saying, let's not even bother vaccinating. They don't have B cells. They're hypogammaglobulinemic. They're not going to respond. So why bother? And I didn't think that was necessarily the complete story. So we wanted to look at it. So we enrolled 2 cohorts of patients during that season. We looked at people that were immediately pre-CAR T cell therapy. They had just arrived at our institution to get evaluated. We administered the influenza vaccine, and we got blood before that, immediately or 2 weeks after that, but before their CAR T cell therapy, and then a few time points after CAR T cell therapy. And then we also enrolled a group of individuals who were post CAR T cell therapy and getting influenza vaccines, and we got pre and post blood samples. And this work was a collaboration with a number of individuals who are shown here at the bottom. So what we saw was that there was a reasonably high proportion of individuals who responded, certainly not zero. And so about 30 to 40% of individuals had a 4-fold or higher increase in antibody titers, which is typically a metric that's thought to indicate a good, robust response. And when you looked at a 2-fold or higher increase, about 60 to 80% of patients in both cohorts had a response. So I think that was really instructive and informative. If you're looking in our pre-CAR T cohort, this is a line plot showing results over time for individual patients connected. So each line is an individual patient. And so these were individuals that got influenza vaccine pre-CAR. And what you can see is in those who did respond, their antibody titers really rapidly dropped after their CAR T-cell therapy. So I think there's clearly value here. You get them a boosted immune response as they're going through the really early high-risk period after CAR T-cell therapy, but it clearly drops. And so I think what's relevant here is for some of the discussions that are ongoing around SARS-CoV-2 vaccines is that these patients really need additional series and additional boosters after their cellular therapy. And that's something that the CDC actually just updated their guidelines to indicate just in the last week. When you look in the post-CAR T cohort, again, we're seeing pretty reasonable immunogenicity, and most individuals are having a boosted response. So I think the takeaway here is that certainly patients are able to respond. What I'm not showing you here are any T-cell responses. This is simply an antibody response. We're doing similar studies right now in patients getting SARS-CoV-2 vaccines, both before and after CAR T-cell therapy. And what we're seeing is that there's an even higher response rate when you're looking at T-cell responses. And oftentimes patients that don't have an antibody response will still develop a T-cell response. So additional reasons to advocate for necessary vaccines in these patients. I think the next really informative piece of the study was trying to look at predictors of vaccine response. So are some of our typical clinical heuristics that we use to say someone's going to respond or not actually good at predicting that in these patients? This was a limited study. It doesn't have that many individuals, but nonetheless, we can see some patterns. So on the y-axis in these plots, I'm showing you the full change in the antibody titers from pre to post-vaccine. Anything above a four-fold change we think is really robust, and two-fold change I think is still clinically meaningful. And we looked at a variety of different baseline characteristics at the time of vaccine. So, one of the typical heuristics is that, all right, someone with severe hypogammaglobulinemia, less than 600 or especially less than 400, is unlikely to respond to a vaccine. And that wasn't the case. We see individuals with total IgG in the blood of 300 who are having a really robust response here, and everything in between. On the flip side of that are individuals with very high levels. Each one of these dots is an individual in the study. And in patients with high levels of total IgG, you can see no response. So this is not a great predictor here. CD19 positive B cell counts is obviously another one. Most people would argue that if you've got 0 B cells in the blood, you're not going to see a response. But indeed, we did have people with 0 B cells in the blood that were responding. And I think, what you're detecting in the blood is just the tip of the iceberg. Some of these patients may have recovered or still have B cells in their lymph tissues throughout the body and could theoretically respond. And again, you see patients with very high B cell counts who are not responding. So a little bit problematic. Same story with CD4 T cells. Same story also when you look at age and months after CAR T cell therapy. We have people that are 5 years out from CAR T cell therapy that were still not responding, but people that were, a year out that had good responses. Leave it to say that this is complex, and I think we don't have a great way of predicting who will and won't respond to vaccines. And I think some of these metrics shouldn't be used to say you should not be vaccinated, because there likely are benefits nonetheless. So a summary from this section of the talk, and I think the overall talk here is that infections are frequent in the first month or so after CD19 and BCMA CAR T cell therapy. Cytokine release syndrome seems to be the main risk factor for infections after CD19 CAR T cell therapy. I think a lot of progress has been made in the past few years in being more aggressive about preempting development of severe CRS. And I think some of the products have different side effect profiles and different CRS profiles. So as we learn to manage this more, we'll get better at reducing the early infections. Seroprotection for vaccine preventable infections in adult CD19 CAR T cell therapy recipients is comparable to the general population. To me, that argues that IVIG may not be necessarily needed in these individuals, and may not be the best stewardship of that relatively limited resource. But I think we need more studies to help us establish that. And really, we're going to need a randomized trial for that. Clearly, the BCMA CAR T cell population has fewer pathogen-specific antibodies, and I think really might benefit from IVIG and certainly need very close surveillance in the long-term follow-up stage. But there are deficits in both groups. Clearly, there are ongoing recurrent infections and sinopulmonary infections to support the need to learn more about vaccine efficacy, when to give them, when to revaccinate people that were previously vaccinated and thinking about immunoglobulin replacement strategies. We still don't know the best prophylactic strategies with antimicrobials and IVIG and vaccinations, but we're learning as we go. But this is a really quickly changing field. There's new products coming out all the time. There's lots of combination drugs that are being used now to boost or maintain responses. So I think we'll have to stay on our toes and be diligent as this continues to evolve. And both the types of therapies, the targets that are being targeted, and the potential for collateral damage, off-target effects, and then the patients that are being treated. So I think that's all I have for you as far as science today. I just wanted to give a special acknowledgement and shout out to all of the people on our team that helped to make this possible. And these are the smiling faces of a lot of really energetic and smart and insightful people that make all this work happen. And my other acknowledgements here for people across VID and the Vaccine and Infectious Disease Division at the Fred Hutch and the Clinical Research Division at Seattle Children's Hospital, at the AID Division here at UW, and others. So thanks so much to everyone that's contributed and to all my funding sources. And yeah, I'd be happy to take any questions at this time.
All right, well, thank you, Josh. That was a lot of progress just in a period of 5 years or so in the CAR T-cell therapy realm and infection risk. I'll start off maybe with a couple of questions, and then Ryan will entertain some other questions that came in the chat. And one is, you said that CRS, after CAR T-cell therapy seems to be one of the greatest risk factor for, subsequent infection. And it may be attributed because they had to get hospitalized, get steroids, et cetera. But I'm wondering if there could be a component of post-CRS immunoparalysis, much akin to what's been described, in the sepsis world, still a little bit controversial, but maybe there's a depressed state of response to a secondary infection. It's going to be hard to tease out, though, because of the steroid effects and all that sort of stuff. But I think maybe there is a parallel between post-CRS immunoparalysis and post-sepsis immunoparalysis.
Yeah, I think that's a really great point. And I think some data to support that point has been coming out in the last year. So a number of groups have been looking at persistent cytopenias after CAR T-cell therapy, and CRS has kind of, has risen to the top as one of the primary risks for that. People that develop more severe CRS are more likely to have prolonged cytopenias in both B cells and T cells, et cetera. So I think that's kind of, at least an objective metric of that. But I agree, it's challenging to tease out, but certainly these are individuals that have an inflammatory state and will probably take a while to fully recover. Plus they're getting tocilizumab and steroids and all of these things that we've come to be really familiar with through COVID, but that can definitely set them back quite a bit as far as immune function and recovery.
Mm-hmm. And just one other follow-up question, Josh. CRS identified as the major risk factor for infection or increased risk of infection after CAR T-cell therapy. How about CRS? Are individuals who have worse CRS, do they have less immunogenicity to subsequent vaccination?
It's a good question. I don't know. Yeah, there's really almost, I think the data I just showed you is the most data that we have for vaccine data. And in our data set there, it was people starting, we only had people at 12 months out. We didn't have people sooner. We're starting to see that though with COVID-19 vaccines. So there's a few papers now with, 10, 14 patients that are reported, and the few that are about 3 to 6 months out almost exclusively have not responded to vaccines, at least with a humoral antibody response. So I think if you get these individuals really early after their therapy, when their B cells are really low, they've had CRS, they've been getting steroids, they're unlikely to respond. So it makes it challenging to think about what the best way to support them is. But I think there's going to be a big role for monoclonal antibody therapy, both in the prophylactic and preemptive type of time periods in these patients, because vaccines are just not going to be that effective early.
Dr. Hill, firstly, congratulations on the award and thank you for an engaging talk and your interesting and important scholarship. I wanted to talk about some questions that came through in the chat, first of which being sort of along the lines of pathogen-specific seropositive protective titers. You touched on this a little bit, but wondering if you could speak a little bit more about our current knowledge of COVID-19 titers in this context, including like clinical utility, and how it may fit in with our understanding of COVID-19 titers in the general population.
Yeah, thanks. It's a great question. And I was quite pleased with myself that I didn't present any COVID-19 specific data in this talk. I don't know if that's refreshing or not for people here, because we hear so much about it. But yeah, it's a great question. I think, is the question specifically about COVID-19 protection in immunocompromised people or in healthy people as well, or?
A little bit of both.
Yeah, a little bit of both. Yeah, I think we're really learning a lot about what's relevant with a vaccine response, and also we're learning a lot about the limitations of what we know about antibody responses and how will those actually predict, are you protected or not? There still is no recommendation from the FDA or the CDC or other regulatory bodies to check or make any decisions based on antibody titers. We have this discussion all the time in our immune compromised patients and others, or if someone gets an adverse event from a vaccine, should they get another vaccine, and is it worth it or not? And how does that relate to their antibody titers? And we don't have a great, we still don't have a great understanding of that. There are data coming out now that there's clearly a dose response relationship. So higher antibody titers are clearly associated with reduced risk, but it's very hard to know how to put all of those together given all the kind of competing factors and risk factors. And also what we're learning is that antibodies aren't the complete story. And so T cell, the T cell component of the immune system is key. Antibodies are helpful for preventing acquisition of infection, but if you do get infected nonetheless, having T cells that are active and engaged in the immune response are key to prevent progression of disease. And I think we're starting to understand that more as well. So yeah, it's a still really complicated space, but we're learning more as we go.
Thank you. A second question that came through in the chat was, are there any differences that you know about in the spectrum or frequency of vaccine side effects in pre-CAR T or post-CAR T populations?
Yeah, that's a great question. And there were lots of questions about that with SARS-CoV-2 vaccines, of course, because our cancer patients with, patients with active cancers and transplant patients and CAR T cell patients weren't included in the large trials and typically aren't. And so far, there has not been much concern in general. We, in our bone marrow transplant patients, they routinely, starting at 6 to 12 months after bone marrow transplant, repeat their entire primary vaccine series as if they're, starting over again. And that's really well tolerated. Some of the live vaccines have to be deferred until their immune system is more competent about 2 years after bone marrow transplant. We're starting to recommend the same thing in CAR T cell patients, but we really don't fully know, but we're not seeing a higher rate of side effects. Some of the concern with the SARS-CoV-2 vaccines in bone marrow transplant patients has been, whether or not you might trigger graft versus host disease, or whether you might exacerbate their underlying immune condition like ITP. And there have been instances of that, and we are seeing some cases of that, but it tends to be pretty rare, pretty easy to manage for the most part. And I don't think the risks outweigh the benefits based on everything else that we know so far, and no clear signal for increased risk.
Another question that just came through is if you could speak a little bit more about why the risk of PJP is increased, since the protection is mediated by T cells and non-antibody response.
Yeah, that's a good question. And we definitely do see pneumocystis, and we have had cases of pneumocystis in this patient population. Our routine recommendation here is to do Bactrim or some other prophylactic approach if you can't use Bactrim for pneumocystis for at least 6 months in CAR T cell therapy recipients. CD4 counts, these patients do get lymphodepleting chemotherapy. They get fludarabine as part of their conditioning regimen, which depletes T cell function for some period of time and can last a while. They're also getting steroids after CRS, et cetera. So, in patients getting rituximab, we sometimes think about this too. I don't have a great response for, aside from the fact that these patients are just very immunosuppressed for a variety of reasons, and it's probably difficult to tease out. But, hepatitis B reactivation has been a problem in patients if they stop their entecavir. We also see that with rituximab and other B cell depleting therapies. You can kind of get this seroreversion of people that are core antibody positive, and it can be a problem. So I think pneumocystis and Hep B and some of these issues we are seeing. So prophylaxis and keeping patients on it is really very important.
Happy to take other questions in the chat as well.
Yeah, Josh, I think that what you said there about fludarabine, because fludarabine is noted to be associated with subsequent PJP, probably is really relevant for these types of patients.
Yeah. Yeah, no, I think so. We're starting to see patients that are getting CAR T-cell therapy plus ibrutinib or plus some other, immune modulatory therapy. And ibrutinib itself is now associated with invasive aspergillosis and pneumocystis. So I think these are going to be additive as we start seeing combination therapies coming down the pike and maintenance therapies. So it's definitely, there's a lot of different risk factors in these patients that we're going to have to be aware of and think and thoughtful about.
So congratulations, Josh. Well-deserved honor in the Fialkow Award. Very interesting talk. Like I said, there's been a heck of a lot of progress just in the last 4 years, that since you've gotten involved with this, and teasing out these immunologic issues, in a human population, not in mice, not in a preclinical animal model, but actually in human patients. And so my hat is off to you. And once again, congratulations. Thank you very much for a great talk, a great example of translational research applied to a patient population with an emerging disease. Thank you.
Yeah, thanks so much. Thank you, everybody.